Well,
Good.
for those of you that don't know, Dr. Patel is dear friend to us here. I know Bob and Ashish know each other, and Ashish and I actually went overseas together and got to serve in Colombia, I think, right? Is that where we
Yeah.
went? I think so.
Yeah.
But more recently, he's a very gifted surgeon, very busy, and I've been looking into some of the dogma of lateral surgery, and particularly as it relates to neuromonitoring and what we're seeing neurologically. And we had some emails shooting around over the last month, and I think they were stimulating enough. I said, hey, why don't you give us a talk on this topic? And he graciously accepted. So without further ado, we are excited to hear what you have to say, bud. Thanks for being
Well,
here.
thanks for having me, Greg and Bob, and so I had Michael McDermott help me with this talk, and I'm gonna. Can you see my screen? I'm sharing my screen right now.
Yeah, it's coming
All
through.
right.
Yeah, it looks great.
Good. All right. So just as Greg said, I mean, what we're doing is we're challenging some of the dogma around lateral surgery. The point being that we all really enjoy the outcomes that we get when patients doing when the surgery goes well, patients doing well. It's by far and away just a superior technique versus, let's say, traditional open posterior based stuff. But there's still some aspects of lateral which we can optimize, and one of those is this like notion, not just a notion. It's actually it actually occurs like where neurological injuries can occur. And so the talk today is on just that, neuromonitoring during lateral surgery, the past, the present, and the future in my disclosures. And I want to start with the case. It's a 78-year-old male, and the patient had a 2-level laminectomy, L3 through 5. Subsequently had a 2-level revision laminectomy and posterior lateral fusion, and then he presents to me. He has some loose screws at L5, and he went on to pseudo both those levels. So, the way that I think through problems these days and is that, I'm going to take advantage of the anterior interbody space, do a lateral at both those levels, place an implant, and fusion rates are very high traditionally, upsize the screws in the back. So I use my typical neuromonitoring setup, SSEPs, triggered EMGs. I think about limited and retracted time at each level. And this was a case where I just started using TMAP, and it's linked with the MVM5. My partner was using this for lumbar fusions, and the tech is like, hey, Dr. Paul uses this. Like, do you want to try it? And I'm like, okay. So it was my second case, and usually what happens is they get pre-positionals. So there's a readout, and I usually start L45. I do the level, place my dilator in there, get decent posterior readings, go through discectomy trial implant, and the tech turns to me after I finished the level, and he's like, do you want to run a TMAP? And I said, okay. So he runs one. It's surgeon driven or tech driven, so it's kind of like a motor modality. And this is the readout. And so just quickly, like green is good. Yellow is, generally a mild or moderate change, but you can see that there's a loss of signal, or red, at the vastus medialis. And this was my second case with TMAP, and obviously it looks bad. I didn't know what it meant, and I go on and perform the lateral L3-4, revise the screws. Fluoros look good. Patient wakes up with a real injury. He had a 2 out of 5 quad. He was buckling post-op day 1 with physical therapy. He couldn't walk without a knee immobilizer. And there was no changes in EMG, and there's no changes in SSEP. And this is the exact case that we're all trying to avoid. This is the first time it ever happened to me. And I didn't know what happened and when it happened. And when I think through that problem, I'm like, when did that happen? I had one piece of neuromonitoring that was telling me that there was a problem. There was an actual problem during the examination, but then there's a whole host of things that I do to do the procedure. Did I do it during the dilator placement? When I placed the retractor, opening the retractor, discectomy, when I placed the implant? I just didn't know. So, that brings us to the talk. I'll be briefly talking about lateral, some background context, and then the neuromonitoring aspect, the past, the present, and the future. I'll be reviewing my experience from a case perspective, like where I've actually had a clinical injury and what the TMAP has shown. And then we'll be diving into the actual data around TMAP. So when we consider, interbody fusion in the lumbar spine, there's just a whole host of things that we could do. But we pursue lateral because, well, it's just a very large interbody that we can place in there. Fusion rates are really high. You can do a wide release, so you can influence both disc height through distraction mechanisms and segmental lordosis really well. So it's a very attractive surgery. But when you navigate that space in the retroperitoneum, you can see that there's a whole host of anatomy that you have to try to avoid. Neural structures, vascular structures, ureter, and through lots of work in the last 20 years, there's been like a 20% adoption rate because there's been a lot of anatomy studies, clinical work. There's been a lot of education around how to stay safe in the retroperitoneum and that trans-psoas corridor. There's also been a lot of neural mapping using cadaver work and MRI work, but you can see as you go distal into the lumbar spine, the neural structures come more anterior. So this is most important when we're doing our surgery at L4-5. I mean, L3-4, all the levels are important, but at L4-5 is where we have the most anterior migration of the neural structures, and so that working corridor becomes more narrow. And when considering all the complications that can occur during lateral, which is the bottom half of this table, infection, peritoneal injury, subsidence, pseudoarthrosis, all this, those are all really small rates. But the things that still plague us, that transient thigh and groin numbness and hip flexor weakness, likely approach braced, but it approaches like 20%, 25%. I tell all my patients that they're going to get it. When they don't, that's great. When they do, they expect it. And so thankfully, this is something that passes after a few days or a few weeks. But this is the one that we're trying to avoid. We're trying to avoid that permanent motor deficit. And when you get one, it's detrimental to the patient's recovery. You're managing it in the office and post-operatively for a long time, and it just really sucks. It's like, you feel really bad when that happens. So that's why we use neuromonitoring. And so in the past, when this procedure was first described, you think about shock bites, going into the retroperitoneal space and doing wide exposures, doing wide dissection of the psoas to find the nerves. Just like you would for a hand dissection, you find the nerve first and then you work away from the nerve. But even when you do direct visualization, when you don't use neuromonitoring, you're prone to having both sensory injuries and motor injuries. And that's the reason why we use neuromonitoring. We want to not only see the nerve, but we want to see what are we doing to the nerve once we retract the nerve. So we're looking for some real-time data. And that brings us to the present. SSEPs, triggered EMGs for neural mapping, transcranial MEBs, like motor modalities, see if there's an actual active nerve injury ongoing, and retractor time. Just like that first case that I described where the EMG didn't go off and the SSEP didn't go off. SSEPs in general, if you look at the study of 1,000 patients, just have a very low sensitivity. You can have an ongoing injury and the SSEP is absolutely normal. Additionally, you can have changes in the SSEP, and it may not mean that there's something going on. So there's a low sensitivity and a low positive predictive value. when we take a look at SSEPs in general in the literature. Transcranial MEPs are added onto that onto the multimodal modality, and just like deformity surgery, we're heavily reliant on some sort of motor, feedback, like what's happening with the neural pathway. It's inseparable when we think about deformity surgery, and it's event-based run. When you're putting in the screws, when you're doing your osteotomies, when you're doing your correction, it's not run like SSCPs in a continuous manner. And when we take a look at this study, when transcranial MEPs are added to the overall multimodal modality, you can see that the authors had a lower rate of neuropraxia postoperatively. Maybe they were using the transcranial MEPs, running them in a manner in which they could avoid an injury, or at least make a maneuver to avoid a severe injury. This paper here, Solis group, and this is probably the most quoted study, the center blade study, when we think about neuromonitoring the lateral. They looked at 300 cases of L45s, and they tried to find a correlation between the change in EMG from the posterior blade, which they were running that every 5 minutes, and postoperative neuropraxia. There was a high false positive rate, so there was a lot of changes in the EMG that didn't correlate to an actual postoperative issue. And unfortunately, there's a high false negative rate, which is unacceptable when we think about neuromonitoring. Imagine, we're doing deformity surgery, and there's no changes, and postoperatively these patients are waking up with huge issues. It's just unacceptable and unthinkable. And so, deeper look into the analysis showed that they graphed all of their cases by time and threshold change in EMG, and they found that, as retracted time increased, the sensitivity with the EMG change improved. And they found that threshold to be in and around the 20-minute, and that's really where the 20-minute rule was created. And ever since that time, there was a lot of education around working in the lateral corridor and keeping the retracted time below 20 minutes. A further study looking just at prone laterals more recently showed that the one patient with a femoral nerve injury had a retracted time of 27 minutes. So they re-reported that retracted time was a huge component of staying safe from neural deficit in the lateral space. And if you think about, when I purposely asked like the community who perform lateral, when you take SSEPs and EMGs and retracted time, like, how do you stay safe in the lateral corridor? And I think people who think through the anatomy aspect, they're like, well, I trace the nerve from L2 down. I see where the plexus is exiting. I kind of have a visualization of where that sits in the psoas. I dock anteriorly. I come posteriorly, and I find where my initial dilator is in a happy space, hopefully around the posterior third of the disc space, and that's where I dock. And so there's maneuvers to kind of limbo around the plexus and not go too posteriorly, so you're irritating the L4 nerve root. But most people still say the same thing, which is I try to keep my retracted time, like really low, 10 minutes, 15 minutes, less than 20 minutes. This was a great study that you guys did, which, when we were reading it, definitely, made me pick up the phone and call you, Greg. And it was, you guys reporting on your cases from back in the mid 2010s, and looking at the rate of injury and the correlations to injury, and then crafting a algorithm as to when you do have an intraoperative neuromonitoring alert, what do you do? Well, it depends. It depends where you are during the actual the procedure. Are you doing disc prep trialing? Have you just docked? Where you are and where you docked, do you have to come more anterior? Were you too posterior? And then what kind of an injury was it? Is it ischemic? Is it traumatic? So I really appreciated this algorithm. I think through this problem in a very similar way. And looking at your data more carefully, when we look at the bottom aspect of the table, the intraoperative neuromonitoring alert and motor deficit, you know, was there an alert? Yes, in 4 cases in which there was a motor deficit, but in 8 cases, there was no alert. And that's really what it is. These false negatives are just plaguing us because we're thoughtful enough that if there was a change, then we'd act on that change. So that brings us to the future, like the limitations of the current modalities that we're using. Unfortunately, still we carry this risk of neuropraxia, and we have to move on. We have to try to find a way in which we're working towards having a 0% rate of nerve injuries during lateral. So saphenous SSCP has caught some press lately. It was introduced a while ago, about 10 years ago, and it's thought of as being a surrogate to motor injuries or ongoing motor issues or neuropraxia because it's the terminal sensory branch of the femoral nerve. And yes, it does. It has some pretty promising data around it in terms of sensitivity. If there is a change in saphenous SSCP, reliably there may be a change that's ongoing, whether that's a motor or sensory issue. Just the difficult thing about it is getting a reliable monitoring for it. It's a deeper nerve, smaller, in the proximal thigh. It's not quite easy to get each and every time. And so our techs are typically monitoring the posterior tibial nerve when we do SSCP, which, quite honestly, doesn't make sense when we're in the lateral space. Transabdominal muscle action potential, or TMAP. This is you can see the picture on the left, patients in the prone position, electrode that's placed around the conus. And then there's another one on the other side around the xiphoid. And so a stimulation is made, and that current propagates down the conus through the nerve roots, through the plexus, and then that's picked up by electrodes in the myotomes in the low extremity. And you run it like a motor during like a typical transcranial motor. You ask the tech to run it. And there's no oversight by the neurologist. There's just not enough data for them to really kind of interpret the numbers and the readout and the display. So it's very surgeon and tech driven. And this is the display. It's pretty user friendly. You can see the left side is the left myotomes, and the right side is the right myotomes. On the top, you can see max stimulation. You can see the specific myotomes, and whenever we're doing lateral, we load up on the quad and L4. So you can see vastus lateralis, vastus medialis, tibialis anterior, and then adductor magnus. So there's 4 channels there that monitor L2, 3, and 4. And then some control, and here it's medial gastroc, or you can use biceps, which is like L5 or S1. You can see your baseline stimulation, and then you can see your current value after you've run one. And then there's a easy interpretation from a green, yellow, red. Green is no change or change less than 150. It turns yellow once you have a change greater than 150 from baseline, and then it's red when you have a loss of signal. And you can see that there's waveforms associated with it, and red is like a flat line. So here are some cases I think you find interesting in which I ran TMAP. After this case, this was the case that I presented earlier. I started running TMAP in every one of my laterals. So like I said, there was no SSCP change, no EMG change. And when I ran my TMAP after I was done, and this was like a 25, 30-minute lateral because I was still learning prone. So it was like during my learning curve. There was a loss of signal there, and it actually correlated to a clinical issue. So asking myself, like, again, what caused this injury? Dilator, retractor placement, shim placement. You could get a a compressive injury. You can get a traumatic injury through penetration. You can get a stretch injury. And then the time component, like during your discectomy, during the implant placement. So I run my TMAPs like I do my deformity surgery and my motors. I run it event-based. When I'm actually doing something, that's when I run it. So we created a protocol where we run it baseline, sorry, and then we run it again when the patient is positioned, dilator placement, retractor placement, shim placement, when we first open maximally, after discectomy, after trial, and then after our implant's placed and when the retractor is moved, and then we go on to the next level. And at the end of the case. So here are like a couple of cases in which I experienced a change in TMAP that correlated to a clinical issue. 77-year-old, I did a L2 through 5 prone lateral. And, you know, I'm at L3-4, and I was placing my trial, and I placed it too far than I usually do on the where it kind of went through the contralateral annulus to the other side. And ran a TMAP because I was done with trialing, and I saw a 550 milliamp increase in my contralateral vastus lateralis and medialis. Finished the case, there was no other changes, and the patient wakes up with right-sided, so contralateral quadricep weakness, which recovered around the 3-month mark. Here's a patient who came in. I mean, you can see from his lateral x-ray, he's pretty flexed forward. He came in on a walker. He had this like large L2-3 disc herniation that he'd had for a couple of months. So he was like hunched over. You know, he was unable to stand up clinically erect. Probably, you know, as we think, to try to open up the canal so he has space there. He also had L4-5 chronic L4-5 issues. So I performed an L4-5 prone lateral and L2-3 discectomy. And per usual, I always start with the lateral. So, you know, we had baselines and positioning prior to positioning, then we position him on the Jackson frame, prone. And, you know, prior to incision, we run one, and you can see that the tibialis anterior bilaterally is red. And so there was a change there, and I'm like, what happened there? I didn't know how to interpret that. I thought that was a system error. And so I continued with my lateral. There was no other changes. Placed my screws, and then went to L2-3, made a incision to do the microdiscectomy. So on the left here, you can see now the display right before my microdiscectomy. By this time, it's like 50 minutes into the case, and there's changes in all the leads, you know. And then on the right, you can see after the microdiscectomy, there's improvements in nearly all the leads, but there's still some leads that are yellow and red. And so we finish the case, the patient goes to the recovery room, and he wakes up with a quadricep weakness and knee buckling, and he never had that pre-op. And so thankfully, this guy recovers somewhere between the 3 and 6 month mark, but you know, he goes from a wheelchair to a walker to a cane, and now walking independently. And you can see on his post-operative lateral, he's standing much better. And so I thought to myself, I must have missed something here. I know that the injury was on the same side as the approach, but it didn't seem like an approach-related injury. You know, the black dilator stemmed well. The TMAPs didn't change during the lateral. No changes in the SCP. And so, you know, by coincidence, I had the same exact case present to me like 2 or 3 weeks after. 4-5 issue, spondylolisthesis, and an L2-3 large disc. And this time, I'm asking myself, just thinking because it's fresh in my head, like, you know, I positioned him again, ran TMAP. This is the second patient. And this time I had, again, complete loss on the approach side of the adductor magnus and the biceps femoris. And so instead of doing my lateral first, this time I did my discectomy first and then did my lateral. Here on the left, you can see the display before the discectomy, and then on the right, after the discectomy. where there's improvement in the leads that were elevated. Went onto the lateral, that went smoothly. There was no changes of greater than 400. And this time the patient woke up with no motor issues. And so that nuance, that change in the approach in which from a procedural standpoint, I did a discectomy prior to the lateral, saved this guy a postoperative injury. Here's a case, L4-5. I'm sorry, here's a case of 2-level pathology 4 through S1. And I did a lateral, or I was planning the lateral L4-5. She had ongoing SI joint issue as well from the long-standing spondylolisthesis, so planning to go down to the pelvis. And I started with the lateral. And you can see from this technique here, even though my dilator reading posteriorly was good, I mean, now in retrospect, I'm looking back at this and I can see that it's posterior. And as soon as I placed the retractor, I lost everything in the approach side, vastus lateralis and medialis. So I closed down the retractor, just like your algorithm. I ran the TMAP again, there was no change. Then I pulled out everything. I ran the TMAP one more time, no change. So I audible to a TLIF. The retractor was in there maybe 30 seconds, a minute. Postoperatively, she woke up with 3 out of 5 quadriceps and knee buckling. She's recovering from her injury, thankfully. And I think to myself, you know, if I didn't have this modality, I could have been in that space for 20 minutes doing the lateral and then finishing it. And either I would have caused like I potentially could have caused a more severe injury here, you know. So if you take a look at this algorithm in the 3 cases that I just showed you, the TMAP picked up the injury after the patient positioned. There was an injury that occurred after the retractor was placed. And then there was an injury that occurred on the contralateral side after I trialed. All right, so, you know, just reported on our cases where we've used TMAP. This is our first 100 cases. And we had TMAP data, SSEP data, and retractor time data. We define injury as 3 out of 5 quadriceps or below, and knee buckling during physical therapy. And the reason why is 4 out of 5 becomes very subjective, or pain issues, or patient effort, or approach-related issues. And so we wanted to have a mechanism in which we were actually examining the thing that we're trying to avoid, which is a 3 out of 5 quad strength. 142 levels, retractor time was around 19 to 20 minutes. And we have 5 total injuries. So looking at SSEP picked up 2 of the injuries, missed 2 of the injuries, and then 1 of the injuries it couldn't pick up because we didn't have any reliable SSEPs on that patient. And so a sensitivity of 50%. When we take a look at the 20-minute rule, there was 3 injuries that occurred less than 20 minutes. And so looking at this graph, SSEP outperforms retractor time of 20 minutes from a sensitivity and specificity perspective. But let's see how TMAP did. TMAP was able to pick up all 5 of those injuries. There was no false negatives. But there were a lot of false positives. It's a very sensitive modality. So if you take a look at the current criteria of what a threshold is, which is anything more than 150 where it turns yellow, we have 100% sensitivity, but very low 40% specificity. As we increase the TMAP threshold to 250, 350, even 450 and 500, you can see that the sensitivity doesn't change and our specificity goes up to into the 90s. So TMAP here outperformed both retractor time and SSEP, which was our current modalities that we used in lateral space. And so this has become a big part of our practice and how we perform laterals. We used our criteria of TMAP greater than 400 now, because you can see that the specificity is high enough, higher than SSEPs. And that's the moment in which I want the tech to tell me if something's going on, so that they're not talking like too much and confusing me during the procedure, and I can focus on the procedure itself. So our intraoperative algorithm is that when we're doing a lateral, I run the TMAP at those events, and the neuromonitoring tech will tell me change less than 400, and I just keep working. If there's a loss of signal, then I close the retractor down, similarly to you guys. And then if it improves, which I've seen that happen, I'll either redock if I'm too posterior, or I progress carefully, opening it less. If it doesn't improve, I abort to a TLIF. And if I run TMAP and it's greater than 400, but I'm almost finished, I'll try to work more efficiently and try to finish quicker. But if it's an ongoing progressive increase, I've got to remove my retractor from that space. So, TMAP has been good for our center and good for our workflow, and we've had really good data from it. And we're trying to, we're performing a multi-center study and to see if the data and the results that we've had also are translatable to more centers, more surgeons. So in conclusion, when we look at time alone, we know that injuries in the lateral space are more than just time alone. Saphenous SSCPs and TMAP are promising real-time intraop modalities, maybe the future of what neuromonitoring looks like in the lateral space. And injuries appear to be not just a stretch injury, which we commonly think of when we think about laterals. We think about it seems to be correlated more to individual steps of the procedure. The dilator, the retractor, the shim, the initial opening. And so we've, come up with that event-based protocol, which has been helpful in our practice. And lastly, we need multi-center data. Like, this is a very brief introduction into this modality, and we've got to study it further, see if it's applicable just not to lateral, but also any posterior-based lumbar surgery. Thank you for your time.
It's awesome, Ashish. Great.
Thank you.
We walked through that. Frustrating.
Yeah, I mean, if you have one, the very first one I had, I'm just like, what the hell is going on? And so, it just makes you try to work really hard to try to avoid this problem. But I'd love to get you guys' take. I read your paper. I enjoyed it a lot. There's obviously a lot of thinking there around like what do you do at what time, and you've been doing lateral for like 12, 15 years. So definitely respect the way that you approach this surgery.
How do you think prone has changed that for you, Ashish? Yeah. Like when you're prone, like do you feel like you lose some of the ability to control the plexus? I mean, you know what I mean? Like, do you feel like that's has it been a negative thing? Or I mean, not negative, yeah, you know what I mean? Like, is the approach a little bit less predictable with the whole quad thing?
I think that you do have posterior migration of the psoas and the nerve roots, just because the patient's extended on a Jackson frame. So the working corridor in theory is larger, but when you put down your retractor in lateral, and you can put down your retractor, there's a gentle force that's downward onto the spine, and you can pull that retractor back just ever so carefully. You know that the nerve root or the plexus is behind you, and you try to center that KY. So you might dock in the 50-yard line and be okay with it. I can't do that in prone. Like, my ability to move that retractor blade posteriorly is limited, and my visualization is difficult. So I look to dock more posterior. Now, the example I gave you intentionally was me not docking thoughtfully. That was way too posterior. And in fact, I think it's more of a L4 nerve root issue than a plexus issue on that patient. But in that way, it's there's some nuance there where I can't move the retractor as much as I want, so I have to intentionally dock more posterior. But one positive thing is that my threshold to abort is much lower because I'm in the prone position. I didn't spend an hour, tape in, strap in, like do my approach. If I don't like what I see with the neuromonitoring, or if my TMAP is showing me like just increase in thresholds, and that's why we use the alert criteria at 400, I'll abort. I book my cases lateral possible TLIF, and I'll abort. And so my criteria for aborting is probably lower. I don't know. I mean, that's in theory. It just depends on the surgeon, but that's the way I think prone has changed the way I perform a lateral.
Yeah.
Hey, Greg, I have a correlated question to that. So, are you comparing your current protocol for this to when you used to do these laterally?
No, I never had that algorithm when I did them laterally. In fact,
how often did you have to abort laterally?
Yeah, I was coming. So the way I was taught lateral was a larger open incision. The approach surgeon would do them at HSS, and it would be taken down Kittner's, direct dissection, look at the disc space, place the KY. It's very different from smaller incision, finger dissection, placing the black dilator under forearms. So
I'm not. I'm Amy Bruffy. I'm one of the surgeons here with Greg and Bob, and I've done a ton of lateral. We originally in 2004, 2005 with Luis. So my question is, when I do lateral, I flex the hips so that the muscle is as relaxed as possible. And so when you guys are doing a prone, you've got that muscle fully extended. The legs are fully extended. In fact, you've got them to do a fusion, right? You've got position for screws. I'm gonna argue that with the plexus relaxed, you have more time and less chance of injury. Even though it's more anterior, it's got more room to be moved. That's been my argument with prone lateral, because you're stretching the plexus. That's just my observation of hundreds of cases of lateral positioning. Just curious to your thoughts on that.
Yeah, I think to answer that question, you really have to do like a comparison analysis of like prone versus lateral, and if the injury rates are similar. But I think there's so many components to an injury rate. Like for me personally, it's like tracing the anatomy, careful docking, probably docking more anterior 80-70, and then moving the dilator back to the place that you want to have it, and then placing your wire to skirt underneath the plexus. That's the way I think of being careful and avoiding injury now. Penetrating just directly orthogonally around the posterior 1/3, that's going to get you in trouble the majority of the time. But it's hard for me to say whether the lateral position allows flexibility of the nerve root and you can move it because it's pliable. In the end, we're both looking to do the same thing. We're trying to dock anterior to it. So I don't know if prone creates a higher risk of injury. I don't know that yet.
Okay.
I had a couple little thoughts too, just based on the evolution, Ashish. One is I'm not so sure whether we're doing ALIFs or laterals. When we work in post-operative settings, like you had this revision TLIFs, and if people have had prior decompressions, probably a little less with those, but discectomies and TLIFs where the nerve roots get scarred.
Yeah.
I always wonder if that's another risk factor that we haven't really appreciated, and
100%.
we probably should factor that in, because
Like that first patient I showed, right? Did I open the retractor and pull tension on the nerve root or the plexus itself? But he had 2 prior decompressions, and that was one of the things that I'm thinking about.
Right.
There's a lot of scar in the canal, and those nerve roots at that point can't take a joke. And if I had run the TMAP and the retractor was in a good place and I opened the retractor and I had immediate change, then that would have told me it. And I think, what it is that running the TMAP like event based, it is really helping me understand at what moment. And I feel that for most injuries, they probably occur from the time of the dilator placement to the retractor opening, not after the retractor is open and you're in a safe space. And when you're in a safe space, I feel like you can spend time and do a good job. Time is always important. It's always important every surgery that we do, whether it's lumbar degen or deformity. I'm not trying to say that time doesn't matter. I'm just trying to say that I don't know if time itself is as important as we say it is.
Yeah, I'm in agreement with you. I mean, I've had two, and one was at 12 minutes of retractor time that we dropped in MEPs, and so I was in there for 12, 13 minutes total. So I'm not sure. I don't think our data's got the power to really tease out the time element adequately. I agree with you.
It's
The
also
other
a
thing
confounder, right? Like if you're in there, if you're a skilled lateral surgeon and you're in there for 25 minutes, that means the case was hard. Like, so in and of itself, like it probably means there's something nuanced about that case that required more time to begin with, which likely equals nerves are at higher risk simply because it's just a more difficult case.
Exactly.
So, especially in our hands where like retractor times are routinely 10 to 15 minutes, right? If we have a 19 to 25 minute, our threshold was 24 in that paper. But like if you have a longer, there's something going on with that, right?
Yeah.
And I totally echo Bob's comment about the decompressions because we see it in ALIFs. I have several post-operative tip and weaknesses from ALIFs where we went in there and just routine, simple, from the front, everyone's high-fiving, and you open that foramen and you maybe open it a bit too much, and that sucker's tethered in the back, and you pull on it, you're just simply pulling on something that's scarred down, like that nerve's gonna go quiet for a while, right? And you image it and there's nothing. Like, wow, the frame is wide open. Why did it go numb on us, right? Why did it have numbness? Why did it have weakness?
So what modality do you use in that moment that's sensitive enough to pick up that intra-op?
They don't pick
None of them pick them up.
Right.
They're never
don't
picked
show
up.
until a day.
Right. So we have a problem. We have a
Yes,
problem.
it's a huge problem
that we need to address.
Yes.
So when I reached out to you guys, like the purpose of it was after reading that paper, like I think you couldn't draw any conclusions from your retractor times because they're just very consistent. But there were some injuries, and then but once we pull our data together, we can really start to do that analysis on people who have 15 minutes, 20 minutes. I'm when I was going through my learning curve, I'm all over the place in it too, and so I think first and foremost, what weight and value do we put to the retractor time? Is there a difference in prone versus lateral? I think we can answer those questions now. And then eventually, like if it's something that continues to interest you guys and TMAP seems like a modality that makes sense to you, or even SAFTness SSCPs, like looking deeper at that and seeing if we can, I even think about those cases where we think about high grade spondylolisthesis and you're doing like a sacrodome, or you're reducing it from the back, and having L5 nerve root issues anytime that you're working around L5 or S1 and doing PSOs and all that stuff. So I run them for my PSO cases when they're in the lumbar spine.
I need to start doing that because I will tell you the even posteriorly based open surgery, I am extremely dissatisfied with the ability of our monitoring to pick up on nerve root issues.
Nerve root is a problem. Spinal cord stuff,
no problem. It's
really
very predictable.
We're really good.
But the number of even cases where we just done posterior work, even just scolies where there's like minimal decompression and minimal, like where you're just realigning patients that wake up with foot drops or whatever. You're like, dude, what the crap? Like I didn't do it. The things were rock solid.
How are you getting the TMAP now, Ashish? I mean, we did it for the study. It was available for that. How
Yeah,
are you doing it now?
Yeah, I remember the study. We went over that data, and I think what was difficult about that study was just really kind of teasing through the differences between 3 out of 4, 3 out of 5, 4 out of 5. Like, there's a line there where this subjective changes in strength testing really alter the way that we interpret data. Even when we start to include injuries as neuropraxias or sensory neuropraxias. So we want to keep it really clean and look at just the motor issues that are 3 out of 5 or less. And I think that helps us at least look at the worst case scenarios, and then we can work backwards from that. So right now, I just every time I do a lateral, I use the MVM5, and so it's available with the MVM5.
Okay.
Yeah, and I'd like to share maybe some of the kind of the worksheet or the protocol that we use, and then there's a video I can send you to show you how I do it. Yeah.
Okay.
Yeah,
I love the algorithm, and the more we collect that data, the more we can figure out the positive, negative, predictive value issues and the right modalities depending on what we're doing approach-wise.
We're deformity surgeons as well, and we rely so heavily on transcranials and SSEPs to the point where if you do have a drop and you release, or you go backwards and you reverse the steps, and then it comes back, and then you'll correct again, and you can use it to your advantage where you can tweak and dial in a correction where you're happy with and the patient's happy with, and the patient has a good exam post-operatively. Like, we can play with it intraoperatively. Right now, we don't have that, but I feel like we can work towards something like that.
That's a good thought. One last thought I had too is just as we're thinking through how we've evolved with laterals, and it came out of this discussion at one of these meetings about anterior psoas, transpsoas, all the debates that we typically have. And I think it probably plays in prone to what Bruff was talking about. I think there's been a migration to some degree towards this sort of middle ground where we think transpsoas, but we're actually moving a bit towards the anterior part of the psoas to try to avoid being in any branch points and being proximal to the neural elements. And just your thoughts about that as you've gone from lateral to prone. Have you sort of felt that same way? And just as some further insight, we were doing a case with I think David or one of the fellows recently, and I literally had to use my finger inside and park what I felt was like completely ventral to the psoas to get appropriate gradient of readings. And the MRI misrepresented that we would need to do that. But as I did that and we worked through it and we did it fine, the patient was safe, I thought, this is just confirmation that we're kind of coming together. We're migrating towards a similar concept of being, not right next to the nerve. We're kind of moving between transpsoas to anterior psoas and finding that middle ground of safety.
Yeah, I agree. If I see a psoas that's anterior, it's pulled the plexus anteriorly, I'm looking to penetrate around like that 90-yard line, find the disc, like palpate it with my dilator and march backwards, angled with an angled dilator. And then if you can kind of orthogonalize your dilator and your retractor and the plexus is okay, well, then you're in a safe space and you can work. My only concern about that is where's that genitofemoral nerve? Is it around? Am I irritating it? But taking a few slivers of muscle, if you describe that as trans, I guess you can describe that as anti, but I agree with you. At 4-5 especially those difficult cases, I'm going more anterior and trying to find my way backwards.
I think a lot. I agree. I think we're all end up doing the same thing. I know Bob and I do similar things. I haven't heard from Jamie on how he does it, but I'm always docking at the 50-yard line or one more anterior, and then moving everything posterior from there.
Yeah.
I actually also think that in my cases where I've had the quad issues, they've been very tight spaces at angles, and I'm needing more force to get the inner body in. And I think there's the nerves don't respond great to vibratory trauma either. And I think there's vibratory trauma sometimes when we're having to use more force to get implants in. And so if you're already at an angle and you're hitting hard and it's pushing, even though you have a shim in place, there's this like posterior vibratory sense that's happening. I am concerned that just the trauma of the vibration is causing some issues with because I've seen that during implant insertion, and I know I'm not banging the nerve, like, it's right there, but because behind me, but something's happening to it, right? So I think those are the other ones where I think there's probably some vibration. So now for instance, now I use slides on everything because that's what, Jamie, I think I was talking to Jamie once. He's like, hey, just use slides on it. And I think that's very true because now you don't need quite as violent of a force to get the inner body in. So
what do you think about like where we had those issues where it was like that large disc at L23 or like the contralateral trialin and I punched through, like where it's picking those, it's really random. It's not really, docking based, but the ability to pick up even those things was
yeah, I mean, it's fascinating, right? But what do you do with the data is the problem. I probably wouldn't abort. I'd probably just keep going because it's contralateral. I know it's not something that's traumatic relative to what I'm doing in my corridor. But
I agree.
Yeah, that just kind of stuck.
Yeah, and I do this. I do the same thing, Ashish. I go across and really set contralateral angles pretty well with my trial, and then but you saw that happen, so you kind of know the causation for that one. So
I put half the trial on the other side, and I sound stupid saying it, but I think I put half the trial on the other side.
Yeah, and I've been there, done that too, right?
You're
like,
yeah, I don't know what you're talking about.
Yeah,
I don't
want to pull that back really fast. Don't save that one. Don't save that one. Right. Don't save that one. Yeah. So I think we've all done that. I still think I'll be very curious to hear as you go forward with the prone lateral, because I'm a dogmatic positioner, and I'm dogmatic about flexing those hips up to get that psoas as relaxed as possible, which I think also affects the plexus. So I'll be curious to see where your conversion rate is, what your injury rate is now, what you're seeing in this prone position, because I think that is the difference maker. I really do.
Yeah, and so obviously there's a learning curve that's tied to go into prone, but yeah, I mean, where the retractor time study that we're doing, there's a mix of prone surgeons, lateral surgeons, and that's what we've got to do. We've got to kind of combine some of the data to really kind of understand if there is a difference between the two approaches. We may find it, and then we have to collect a lot of it. The nuance may be very small, or it could be very obvious. So the point is for me to continue to collect this data and partner with people like you guys and combine data and see if we can really make a difference here.
Yeah,
great.
Well, that's great.
Our data's coming, man.
Well, thanks.
So I think we should be sending it to you this week.
Awesome.
Should be
Thank you.
imminent.
Yeah. Well, appreciate it. Thanks for having me, guys.
All right, guys.
Thanks,
Appreciate
Ashish.
you. Great job.
Thanks for doing it.
Have a great
Thanks.
day.
Bye now.